Thank you very much, Klaus. I don't know if I could do this in Danish, but I'm probably skip to stay with the English. Thank you for inviting me to this very nice symposium. Seeing all the psoriasis enthusiasts here and friends and colleagues, it's really a privilege to be here and to be part of this group. We are here, unfortunately, in an ivory tower, because when I would like to talk to you about treatment strategies or targets and ask you to treat your patients, you all know about targets and treatment strategies, and you will treat your patients at the best possible way. But this is probably not true to the vast majority of psoriasis patients, because they are being cared by normal dermatologists without special knowledge on psoriasis or about psoriasis. So what can we do to lift up the standard of care for those? And this is what my presentation is all about. To give you an example why this is so important, in Germany, we have only 40% of the dermatologists in private practice that prescribe modern drugs to their psoriasis patients. They may rely on textbook knowledge. This is 20, 30 years old, according to investigations we have done on the knowledge, and there's a tremendous knowledge gap by today. So what I would like to do is, again, to show you how we try to overcome this nasty situation and to try to improve not only the patient's life, but also making the dermatologists believe that what they are doing when they use this modern kind of treatment and management is also rewarding for them. So this is one of the principal figures we are using for this, and it's an educational figure. You may disagree to some of these things that are described here, but for educational purposes, it has been found to be helpful. We call this the Kiel cake, and what you see is that the outer sphere here is what we term psoriatic disease, and we try to use the term psoriatic disease because, for example, in a very well-known German newspaper some years ago, psoriasis was called a cosmetic condition, and it was negotiated, or it was described that spending a lot of money for drugs on a cosmetic disfigurement would probably not be helpful for the healthcare system. Well, I was a little bit too fast. So to also mention that psoriatic disease really exists, we have psoriatic disease defined for 3 domains. That is, one is the inflammation of the skin, then vascular inflammation leading to atherosclerosis and their consequences, myocardial infarction, stroke, and also being psoriatic arthritis being part of the psoriasis disease spectrum, not being a comorbidity. Because we think that is an early on disease, whether it's now according to the stress theory of Dennis McGonigal, or it's a true immunologically mediated condition, we don't know, but it's part of the spectrum. And then we have this important sphere of comorbidity. And comorbidity definitely adds to the severity definition of psoriasis. And our common severity definitions are not dermatology made. They are made from regulatory bodies such as the FDA or the EMA, not dermatology made. We also pay attention, or we want that the doctors pay attention to triggering factors. We have done an investigation, for example, therefore stress it's a little bit higher, it's a little bit larger here. When we ask psoriasis patients about a situation where the disease is deteriorated, and many of them would say, yes, I know the situation. When we ask what is the triggering factor, over 90% of these patients will answer stress. Stress mainly at occupation or an educational phase, followed by familiar stress and partnership stress. So there is, for me, an absolute need to ask our patients, particularly those who we term difficult to treat, if there is a stressor present. The risk factor sphere is really difficult because obesity is also no longer a comorbidity, but it's an underlying risk factor, and we know from many studies that this is an independent risk factor for psoriasis. And there are studies out there from Denmark and from Sweden in cohorts undergoing bariatric surgery, that those who underwent bariatric surgeries compared to those who kept their high body weight, that the likelihood to develop psoriasis in a 15 years period is half in the bariatric surgery group compared to the group that was not undergoing surgery. And of course, the genetics is something we've talked about a lot. From the risk sphere to the comorbidity sphere, it's the chance for management, for the dermatologist to keep an eye on all these different parameters of psoriatic disease. So this is a challenge, and we need to be convincing, and we need to be a little bit logical with and consistent with what we are telling our dermatologists. So common pathways, common targets. So we take what we know about the pathophysiology of psoriasis, break this down to a level that is easy to understand. So we talk about signature cytokines, signature cells, and signature tissues. And for signature cytokines, we've heard a lot about IL-17, IL-23, but also TNF-alpha, etc. Dendritic cells, T cells, neutrophils are the dominating inflammatory cells, and of course, you know that the cells, the keratinocytes and fibroblasts play also a role, but not as cells that are heavily involved in this inflammatory scenario. We can tackle T cells, for example, as a target. So the signature tissues may also include the central nervous system. I'm going to come to this when I talk about depression at the end. We also try to make them believe that, and we have heard about this psoriasis progression and the possible importance of tissue memory, not only in skin, but may also be in the joints. That is important to memorize that when we will be able to get rid of a memory, we need to treat early. And we need to treat early with the highest efficacy drugs. But in the community, at least this is the case in Germany, it's the common paradigm is to save the best for last. So they all start with methotrexate, fumarates, or other drugs where we know that the level of efficacy is very limited. And they go through the sequence until they're coming to the high-level efficacious drugs, such as the risankizumab that was just mentioned here. So we have to educate them that in certain patients presenting early with a severe disease, there's absolutely a no-go to go through the sequence, but to start early. But the first drug must be a drug that is highly efficacious, whether this fits into their thinking of budget or not, to get rid of a memory development and the theory behind the dermatological memory development was discussed here at length. So in IL-20, the microphone broke. Thank you. Okay, let's lift this up again. Good. Okay. So, and again, we have heard great talks about memory and the theory behind this memory. And we have seen the studies that are at the moment addressing this kind of concept, the GUIDE study and the STEP-IN study, with two different principles, so IL-23p19 and IL-17A inhibition. And I'm really, really looking forward to see data, because these data could be really convincing for this new concept of early treatment, at least in a subpopulation of patients. And we have seen from Mona Stahler's group this nice scheme where we have the chance to achieve maybe a proportion of 20% with this deep response, where we have psoriasis, we treat early and with an effective drug, and we may induce this deep response. Well, comorbidity is also part of the severity definition of psoriasis. And we also need to check our drugs for the ability to improve the comorbid conditions we know that are important for psoriasis. And this is some recent data that we can also communicate a certain logic behind this. This is for a coronary artery disease, and recently published the overlap between psoriasis and arteriosclerosis. And you can see here that leading to coronary artery disease. And you can see that there are common cytokines that are related to coronary artery disease and psoriasis, including IL-17A and TNF. So by using anti-IL-17 family targeted treatments, we may be able to improve the comorbidity coronary artery disease part of the atherosclerosis consequences. Do we have data for this? Yes, we already have data for this. It's just one example from a study that was performed in Germany with secukinumab, so an IL-17A based treatment with the surrogate marker of flow-mediated dilatation. This is the baseline situation, and it shows you on the left-hand side, the gray box is the psoriasis population, and the purple box is the control, the population control. You see that there's already an impairment of flow-mediated dilatation in the psoriasis cohort. So if these patients were treated with secukinumab, you saw an improvement of the disease, a treatment effect, but this treatment effect was only pronounced after a year of treatment and not on a short-term run after 12 weeks. This is the first column. So we do have some data. There are also data about the anti-TNFs, that they can improve this kind of vascular inflammation that can be incorporated into this thought of a comprehensive management. We have just heard elegantly about psoriatic arthritis. And again, regardless of the pathophysiology, I think from a pragmatic point of view, we all want to have our patients with a possible development of psoriatic arthritis being treated early to prevent joint destruction. There's the need for dermatologists having a real good knowledge about psoriatic arthritis. And the reason is, again, the healthcare system. When we want to refer a psoriasis patient suspicious of having psoriatic arthritis to a rheumatologist, it will take us about half a year to get an appointment, and it may be in a network, it will be 3 months or so. But in this time frame, and I know that in many countries of the world the situation is alike. So in this time frame, when there is a real progressing arthritis, we can already have joint destruction when the patient is seen lately by a rheumatologist. So what are the risk factors for psoriatic arthritis that can be detected by a dermatologist? And there's, for example, nail involvement, but there's also obesity, psoriasis, severity, family history of PSA, and we have heard about joint pain and arthralgia as also being predictive for later developing psoriatic arthritis. And what we don't want to have is that from the early, very early subclinical PSA to new onset PSA, that we haven't initiated a treatment here. So we do not want to have this overlap, and we will be very, very early. To be very early also means that a dermatologist already starts treatment when there's suspicion of a psoriasis patients may develop psoriatic arthritis. And we are in the very lucky situation that we have a number of drugs that are licensed for that have a label for treating moderate to severe psoriasis, and that have a label for treating psoriatic arthritis. So there can be a preference for these kind of drugs in this particular situation. So one more word to comorbidity. You know, there's a long list of comorbid conditions, and recently we have made a deeper look into depression, because according to studies that are done in Sweden and other countries, 1 out of 5 psoriasis patients not only have the diagnosis of depression, but are also treated for depression by psychotherapy or by respective antidepressants. So 1 out of 5 psoriasis patients, that's a huge number. And we all know that depression is heavily impacting treatment adherence. So the treatment success is depending also on the treatment adherence, as you all know. So when we put our drugs on a list and ask them what are they able to do, what is the performance of these drugs, and that's a personal view of mine, this table, then we have some very good data for some of the drugs, we have no data from some of the drugs, and we have conflicting data. For example, phototherapy, that is a mainstay of treatment in many, many countries. We know that can have a very nice effect on skin, cannot be used for long-term treatment, but there's there's no effect on the important inflammation on the joint and the bone level. The data on vascular inflammation are very sparse, no data on depression, for example. Methotrexate, it's really dependent to use it in the joint situation on the subtype, the clinical phenotype of psoriatic arthritis, whether it is a peripheral arthritis where it's still recommended, or whether it's axial disease where it is not recommended. And it's sometimes forgotten, and unfortunately I see many patients treated by rheumatologists with, for example, axial disease, and their first-line treatment is methotrexate. No wonder that the patients are still having pain during this treatment. But there's nothing known on depression. But there are drugs where there's data already on the comorbidity depression along the clinical trials they have performed. For example, many of the IL-17 trials used the HATs for anxiety and depression and could show that during treatment there was an improvement of the HATs for anxiety and depression. And there are other drugs where this was not the case. So again, the selection of drugs is important for improving this standard of care, and to not only keep an eye on the 3 domains of psoriatic disease, but also on the sphere of comorbid conditions. Well, so the major treatment or management targets today are summarized on this slide. What we take to treat our patients should have a positive effect on all domains of psoriatic disease, so skin inflammation, vascular inflammation, bone joint inflammation. We should also keep in focus on comorbidity, and I've shown you with the depression that this is just one aspect of comorbidity, but it's a very important one because impacting adherence and of course also drug survival. But we also should ask about risk and trigger factors. With the risk factor obesity, I feel very helpless as a dermatologist because I tried so many times to make my obese patient to lose weight, but my success rate is potentially 0. And I think that this is more a political problem and a problem of the prevention of becoming obese. And we should address this to our healthcare politicians, and probably we are last to tackle this. When we do all these and we consider all these factors on this list, what we do is what we aim for. It's individualized, personalized treatment in the sense of precision medicine, but on a practical and pragmatic way. To end, I would also pay an attention to this, and this is the patient itself. We pay attention to scientific data, but sometimes we forget to talk to the patient. And now we see the clinical science, we can judge the clinical science, we can do PASI and other stuff, but we tend to forget the emotional, the social aspects of the disease. And again, to tackle this is important for treatment success and for example, drug survival. And we are in good company because this rethinking of psoriatic disease is a program made by the World Health Organization and started already 2007. And the main here is this first phrase. It means shifting away from asking what is the matter with you to what matters to you. And from the patient's perspective, this is really, really important. But also from the doctor's perspective, it's important because when we address this and the patient is full trust, we can apply a treatment that's helpful, then it's very rewarding for the treating physician/dermatologist. Well, I come to my last slide. So I think that the evolution of the concept of psoriatic disease for me is a major breakthrough for optimized management. In psoriatic disease, there are numerous targets for treatment, intervention, management. And when we do so, personalized care is what we achieve. And this is important to address patients' needs. Thank you very much. You could better take this one here.
Yes, no. It just had to get working. Okay, questions? Well, yeah, okay.
Yeah, Uli, maybe the $1 million question. You say there's a subgroup which we should treat very early. And being a pediatric dermatologist, seeing all these young children, the question is, which subgroup should we treat early? And I know you don't have a clear answer, but what's your thoughts? What are your thoughts?
Well, it's maybe a $10 answer. At the moment, we do not have enough data. One interesting topic was addressed earlier, and that's tonsillectomy. Tonsillectomy, and you've seen tonsillitis in the triggering factor sphere of my keel cake. There are in early development, for example, in an adult population where people present very early on with severe disease. It's not only drug treatment that's important, but, for example, paying attention to that. We have done a study in more than 60 patients without the history of tonsillitis, just patients having tonsils, sometimes tonsils that were enlarged, but they without infections, etc. And we have submitted these patients to tonsillectomy. And the disease severity went down in most of the patients and stayed stable over 2 years when we ended the observation period. So that's also a management procedure that's probably leading to the subpopulation where we can achieve a deep response. If we are able to achieve this with a drug at all, that will be answered by studies like GUIDE and STEP-IN. And I have no answer to the rest of the value of the $1 million question. Sorry.
Yes. No. I think there were a lot of questions. Please, next question.
Also a financial question. I can see how earlier treatment is easier for us, but from a preventative perspective, if we would spend the $15,000 a year treatments on obesity, smoking, etc., overall health benefit we might achieve might be much larger. And I understand that the individual clinician saying, I have to reduce the BMI of my patients, it's a nightmare for me, for you, for everybody in the room. But as a society, I'm not sure whether this is a wise investment.
I fully agree. If we would be able in a society to achieve this goal, I'm totally with you. But I'm fully frustrated. And we have developed a program for weight loss tailored to our psoriasis patients. The acceptance rate was below the carpet, and really the outcome was maybe 1 or 2 patients lost weight for a period of time, and thereafter they presented with their own weight status. So therefore, my opinion that this is more a health political problem than a problem of doctors. I have a very good friend, he's a general practitioner, and he sees so many overweight patients with all these diseases that are dependent on weight, and he absolutely shares the same frustration with this.
Okay, just, okay, yes.
I'm just going to ask you, how big of a problem is compliance? I'm just surprised that that hasn't been mentioned. So
yeah. So adherence and compliance are measuring virtually the same. With biologic drugs, for example, that are given maybe every 3 months and may also be given by the nurses, the doctors, the nurse practitioners, the adherence rate is 100%. With drugs that are, for example, tablets or drugs that are self-dosed, even with biologics, we know from a Bedbeer analysis that even with, if I remember correctly, etanercept was around 20%, and even with adalimumab, so a very powerful drug, it was in the range of 15% non-adherent behavior. So that's really a waste of money, Tamar, and it's not.
They don't use it.
Yeah, if they don't use it or they sell it.
Yeah, well, that's one of my patients.
Yeah. They for example, half the dose and half the dose is sold on the darknet. That's sorry, it's a common experience.
I just want to mention that Lona and I, we did actually spend some money that was supposed to be used for physician to hire a dietist, and it didn't help a damn thing. I think we actually persuaded 100 patients, and I think 2 of them lost weight.
For how long?
As long as they went, but 2 patients out of 100 lost weight with a dietist. At the department, they could go into the dietist after they had been at our department. It didn't lose, but Novo Nordisk is doing quite well at the moment with Wegovy and semaglutide. So I know that the value of the company is 3,000 billion kroners yesterday.
Yeah, congratulations, Klaus.
No,
but this will be a new dimension of
Yes.
maybe getting rid of this problem because many patients have diabetes type 2 and insulin resistance, and if we could, maybe this is a subgroup we could study where we use this new ways of treating diabetes with weight loss and see if this alone is able to improve psoriatic disease. Interesting study.
Well, I'll bring up a quote by Craig Leonardi that's relevant to this, and that's when he talks about step therapy and doctors delaying using, he uses the term the ladder of shame. The steps and steps and steps. And, you know, another past president, Lexa Kimball, reported just the life impairment of having psoriasis is huge, right? And so it just doesn't make any sense to step therapy ladder like this and make people suffer for years and years and years, but he calls it the ladder of shame.
Ladder of shame will be a nice term to use. Thank you.
Okay.
I will quote Craig.
Thank you, Uli.